Good afternoon, everyone. We'll get started in about 1 minute. Okay, good afternoon, everyone. Welcome to Medical Grand Routes. Before we begin, I'd like to make a brief land acknowledgement. McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous peoples. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which people of the world now gather. Just a reminder to please enter your questions in the chat. Leave them till the end of the presentation and enter them in the chat, please. As well, please answer a brief survey that will be sent to you after the presentation. This will let us know that you are here today. And finally, our speaker today is coming to us courtesy of the Division of Hematology. And I would like to ask Véronique Naissance, the co-director of the hemoglobinopathy program, to introduce our speaker. Véronique, thank you.
Thanks, everyone. And thank you, Jacob, as well, for accepting the invitation to speak to us today about a fantastic talk. And I think all of us here today will find this very important because we all do see these patients not only in clinic for myself, but colleagues in internal medicine, in the emergency room, and on the wards. So about Dr. Jacob Pendergrast, so he has graduated in 1999 from Dalhousie Medical School in Nova Scotia. He has trained in internal medicine, hematology, and finally transfusion medicine. And in fact, he is the medical director of the Transfusion Service at the UHN, so in Toronto. He also works in the clinic, taking care of patients also affected with hemoglobinopathies. He's very active as well in research, and he holds a position of Clinician Investigator at Toronto General Hospital Research Institute, and is a founding member of the Quest Research Collaborative, which focuses on issues of quality, utilization, education, and safety in transfusion practice. His research interests include transfusion, but also education in serology and transfusion reaction. And he is going to speak to us today again about transfusion support in sickle cell disease. Thank you, Jacob. And we will be excited to hear your thoughts.
All right. Thanks so much, Veronique. Appreciate the invitation. Yeah, it's good to be invited to speak on this topic. It was a great experience working with Veronique when she was with us in the Red Cell Disorders program at the University Health Network in Toronto, where I still work. And this is a subject which is near and dear to my heart because I also, in addition to seeing patients in that clinic, as she mentioned, work in the blood bank at UHN. These are my disclosures. And as indicated on the poster, these are my learning objectives to go over the principles of red cell transfusion and sickle cell disease, the accepted indications, and the risks, particularly the risk of hyperhemolysis, which is a condition I want everyone at the end of this talk to be familiar with recognizing and have an approach for managing. So we encounter sickle cell disease patients in many different contexts and environments. Probably one of the most common interactions for people in internal medicine is when they come to the emergency department in a pain crisis. And when you encounter a patient like this, one of the decisions you're going to have to make at some point is, do I need to transfuse this person or not? Transfusion in certain circumstances could save her life, and in other circumstances could kill her. And knowing which one you're going to get and knowing when to pull the trigger on doing a transfusion and hoping for the best outcome requires really understanding the pathophysiology of sickle cell disease and how transfusions interact with that disease. It's very complicated, and the rules are really quite different for sickle cell disease versus other patients. So, what is sickle cell disease? This is a congenital disorder of hemoglobin. And hemoglobin, as we know, moves back and forth between an oxygenated and deoxygenated state. And with sickle cell disease, because there is a mutation which results in a hydrophobic domain on the beta globin chain, which is only exposed when the hemoglobin molecule is deoxygenated, as a result, you have these episodes where the hemoglobin begins to polymerize. It comes out of solution, it forms these long polymers, which deform the red blood cell, stretching out the membrane, damaging the membrane, leading to the loss of water. You had a denser red cell. The membrane becomes rigid, sticky, and brittle. And as a result of that, you have the two cardinal features of sickle cell disease. One is vasoocclusion, where the red blood cells block up small blood vessels, and even in larger blood vessels, lead to damage to the endothelium and progressive vascular stenosis, all of which results in the loss of oxygen delivery downstream. So this is sort of the vasoocclusive aspect of sickle cell disease. And then there's a hemolytic aspect where the destruction of the red blood cell in the circulation releases all sorts of toxic substances into the plasma. Free heme being a really important part of that. Heme having various effects that we'll talk about later in this discussion, but among them are scavenging of nitric oxide, leading to vasoconstriction and damage to all sorts of parts of the body as a result. It's been said that if you truly understand everything there is to know about sickle cell disease, you really understand everything about internal medicine because it is a multi-system disease. In many ways, like a vasculitis, in that you have almost any organ can be affected. And some of that is a result of vasoocclusion, some of that is the result of chronic hemolysis. And every patient is different. They'll be different based on their particular genetics. They'll be different based on their particular environmental exposures. But there is also a progression in how the disease manifests over time. And in this study, looking at causes of death in patients with sickle cell disease, younger versus older than age 20, you can see that in younger patients, infection is a very common cause of death due to the loss of splenic function and other causes of immune suppression. And then as you get older, you have more death from irreversible organ damage, kidneys, liver, lungs, brain. All of these things can be progressively injured over time, leading to chronic organ failure. And for many years, as a result, sickle cell disease was considered to be a pediatric condition. Many patients didn't make it much past age 20. In fact, even as recently as the 1970s, the average life expectancy was probably around 15 to 20 years old. And it was only with the development of first prophylactic penicillin before age 5, then hydroxyurea, which is a very important foundational medication for sickle cell disease. And then finally, with the judicious use of blood transfusions, did we see life expectancy start to really surge? And so we now have in North America a life expectancy of approaching 60 years old. We don't know exactly how many patients there are in Canada, maybe between 5 and 10,000. In the United States, it's been estimated to be 100,000 patients, and the net cost to the healthcare system is substantial as a result of this. Much of that cost is a result of poor quality care. If you provide better quality care to these patients, they end up not only living longer, but being less of a burden on the healthcare system. So there's a lot of work we need to do to improve the quality of care provided to sickle cell patients, particularly amongst adults. And one of the things that we need to do is to understand how to use transfusions, how to apply them in a way that does more good than it does harm. So to understand the pros and cons of transfusing a sickle cell patient really means that you need to understand the competing effects that transfusion has on oxygen delivery. On one hand, transfusion will improve oxygen delivery, and on the other hand, transfusion will worsen oxygen delivery. And this is a balancing act that we need to consider for any patient. Most of the time, we are only thinking about the macro circulatory perspective. And by that, I mean we are thinking in terms of oxygen delivery as a function of the oxygen carrying capacity of the blood. So we know that oxygen delivery is cardiac output times the oxygen carrying capacity of the blood, and the oxygen carrying capacity of the blood is defined mostly by the hemoglobin. Ergo, if you transfuse, you will increase the hemoglobin and you will increase oxygen delivery. This is what we are often thinking about when we decide to transfuse a patient. So I'm going to improve their oxygen delivery by increasing their hemoglobin. But there's another effect when you transfuse, which happens mostly in the microcirculatory perspective that we don't often think about. And here we know from the laws of fluid mechanics that the increasing viscosity of a fluid will slow the flow of that fluid through a vessel. And that effect is particularly heightened when you have a vessel with a small radius, because you can see that's to the fourth power of the radius that flow correlates. And what determines the viscosity of blood? Mostly it's the hematocrit. Ergo, if you transfuse, you will increase the viscosity of the blood, you will slow the flow of that blood, and you will have less oxygen delivery. So these are these competing effects. And this is what I mean that transfusion is a balancing act between these two perspectives, the macro and the micro circulatory perspective. And we know that if you are too polycythemic, you will have less oxygen deliveries. Patients who have P vera will often complain of headaches or dyspnea as a result of the fact that their blood viscosity is too high. But that typically only occurs when your hemoglobin is over 200 or so, which is not a condition that we see commonly, so we don't ever have to really worry about this. With sickle cell disease, though, their blood is already viscous. And as a result, that ceiling effect where the microcirculatory effects of transfusion begin to outweigh the macrocirculatory effects, it's at a threshold of around 100 or so. And that's actually in the best case scenario. That's when you're transfusing somebody into a high shear vascular bed, when the patient is relatively well, when they are not dehydrated, when they're not hypoxic. What is shear? Shear is the effect that pressure gradients have on the flow of fluids. And blood is a shear thinning or non-Newtonian fluid, meaning that the higher the shear you apply to it, the lower the viscosity. The blood lines up in these nice long laminar flows and it moves fairly efficiently. But when you have a low shear vascular bed, the blood flow becomes more turbulent. There are more protein cell interactions, and the blood actually thickens and becomes more viscous. So, considering these two effects, viscosity and shear, there have been some experiments looking at what the effect of transfusion on oxygen delivery is, specifically in sickle cell disease. And so this graph here is a graph of the hematocrit to viscosity ratio on the y-axis. And the higher you go on this axis, the worse your oxygen delivery is going to be, because your hematocrit is going to be climbing at a higher rate. So the ratio of your hematocrit to viscosity will be climbing while your hematocrit is climbing, meaning that your viscosity effects will begin to outweigh your oxygen delivery effects. And so these are experiments where they looked at what happened to the HVR as you increase the hematocrit at both high shear and low shear. And at high shear, you can see that the viscosity effects begin to outweigh the hematocrit effects. You get that sort of flex in the curve here. at a hematocrit of around 25 to 30%, meaning that if you transfuse any higher than that, you actually begin to worsen oxygen delivery. And this is even with the dilutional effects of transfusing non-sickle blood, which is what this dashed arrow indicates. So that dashed arrow will decrease your hemoglobin S percentage, but you will also lose your oxygen delivery by increasing the overall viscosity of the blood. At low shear, you can see here that as you increase the hematocrit, the viscosity increases at a faster rate than the hematocrit does, suggesting that transfusing in this situation may actually worsen oxygen delivery, even with very low hematocrits, like hematocrits down to 20% or so. What does this all mean in terms of clinical practice? What this means is that you have to think about what part of the body you are trying to improve oxygen delivery to when you're transfusing a sickle cell patient. If you are trying to improve oxygenation to the brain or to the lungs, you may actually improve those things by transfusion, so long as you don't get any higher than 100. But the most benefit, of course, will be by decreasing the hemoglobin S percentage at any particular hemoglobin level. But simply by giving a top-up transfusion, you will both be increasing the hemoglobin level and decreasing the hemoglobin S percentage. And so long as you remain within this ceiling here of a hemoglobin of around 100 or so, you should be okay. In a low shear vascular bed, however, such as the post-capillary venules of a bone marrow, which is typically where vaso-occlusive crises are occurring. This is where the ischemia is happening when patients have a pain crisis. Transfusing in this environment may actually make the patient worse. So, rules of thumb. In most cases, transfusing a patient will benefit them by anything you can do to decrease the viscosity of their blood, i.e., decreasing the hemoglobin S percentage, rather than by increasing the total hemoglobin. And transfusing to a hemoglobin greater than 100 will worsen their condition and may worsen it even at lower hemoglobin thresholds if they are having ischemia to a low shear hypoxic vascular bed, i.e., in the setting of a pain crisis. Sometimes you can only get your hemoglobin S percentage down without exceeding that hemoglobin ceiling of 100 by taking blood out of the patient first. And this is why exchange transfusions are such an important part of sickle cell disease, because we're trying to decrease the hemoglobin S percentage with the blood that we're transfusing, while also not keeping the total hemoglobin too high. Do you ever need to transfuse just to increase the oxygen carrying capacity rather than to decrease the viscosity? Yes, there are situations where there is simply too little oxygen carrying capacity in the blood of a sickle cell patient. But most guidelines state that you shouldn't even be thinking about this until the hemoglobin is less than 50. Keeping in mind that the oxygen dissociation curve of sickle cell disease is right shifted, and keeping in mind that many of the symptoms that you think may be due to anemia are actually due to a pain crisis or something else that brought the patient in, i.e. they're having pneumonia, and that's why they're dyspneic. So you have to be cautious when you transfuse just for the setting of anemia. First of all, make sure that the symptoms the patient is having are truly from the anemia. And second of all, be aware that you probably have a lot of margin to extract oxygen from your existing oxygen carrying capacity all the way down to a hemoglobin of 50 or so. Are there ever situations where you would need to transfuse because the hemoglobin is less than 50? Yes, this does occur with sickle cell patients. It can happen because they're having active hemorrhage, in which case you need to keep up with what's being bled out. It can happen from hemodilution, in which case you need to be careful not to misinterpret that fall in hemoglobin because the oxygen delivery has actually not decreased when you've hemodiluted a patient. But in situations where your red cell mass has truly dropped significantly, You may need to transfuse, but you really need to be very careful in understanding what drove the hemoglobin so low, because there are different risks and benefits of transfusing depending on what that cause was. So an aplastic crisis, a sequestration crisis, and hyperhemolysis could all drive your hemoglobin less than 50. But you have to know which one you're dealing with, because that will totally change how you approach the transfusion decision. What is an aplastic crisis? This is most commonly seen in sickle cell patients when they develop their first erythrovirus, aka parvovirus B19 infection. And this will manifest first with a rash, then some arthropathy, and then the retics will fall. This happens to any patient who develops a parvovirus infection. It typically lasts a week and then you recover. But you'll notice it with patients who have hemolytic anemia because in that 1 week when their retics are low, their hemoglobin will drop very quickly. And that drop may be 30 grams per liter or more. The important thing to note, however, is that the fall occurs fairly gradually, like over several days, meaning that the overall blood volume has equilibrated typically by the time the patient comes to you for care. And so if they walk into the emergency room with a hemoglobin of 40 because they've had an aplastic crisis, if you panic and give them 3 units of red cells in a row, they may end up with volume overload because they're already volume replete by the time they have presented to you. A sequestration crisis is different. This is where you have rapid sequestering of red cells, typically in the spleen, before the age of 12 or so, and then after that, it can occur in the liver. When it occurs in the spleen, this can be life-threatening because the spleen can expand to much greater degrees than the liver can. And as a result, you can have a fall in your hemoglobin that will occur within hours of a sequestration crisis, meaning that the patients can actually develop shock. And if you don't intervene quickly, then that patient may die. And so splenic sequestration crises were a common cause of death in pediatric sickle cell disease until the medical profession recognized it and taught parents how to recognize it as well. And through the judicious use of transfusion, these patients can be saved. However, the transfusion has to be given in small volumes because many of the sequestered red cells will be released back into circulation as the blood viscosity begins to decrease. And you therefore risk polycythemia and hyperviscosity if you give too much blood. So typically, for a pediatric splenic sequestration crisis, you might only need half of the volume you would normally be giving, like 5 to 10 cc's per kilogram. In an adult patient, you might just want to give 1 unit of red cells and then check the hemoglobin afterwards, and you may find that it's much higher post-transfusion than you were expecting. So transfusion can be life-saving in sequestration crisis, absolutely, but give it in small volumes. Hyperhemolysis is a syndrome in which patients begin to hemolyze the blood that was transfused to them, typically within the past month or so, like maybe up to 21 days. And it manifests in a fall in hemoglobin that results in a degree of anemia that was worse than before you transfused them. So you transfuse a patient with a hemoglobin of 60, and they come back a week later, and their hemoglobin is 50. Give them another unit of blood, it comes back at 40. Give them another unit of blood, it comes back at 30. All the while, the LDH, the bilirubin are climbing higher and higher. You see the retic count begin to falter a little bit. And if you do a hemoglobin electrophoresis, you will find that the blood that you transfused, the hemoglobin A containing blood, has been rapidly cleared from circulation. If you try to investigate why this is happening, only a third of cases will you be able to attribute this to an antibody against the red blood cells that you transfused. So other situations, you will find antibodies that don't appear to have any particular specificity. And in other situations, another third, there'll be nothing there at all. So it's a type of delayed hemolytic transfusion reaction, not entirely clear the degree it's due to serologic incompatibility. But in this situation, if you transfuse, you may end up killing your patient because you'll make them more and more anemic. So we'll get into what you should do instead later on in this talk. But the key thing is that you should only be transfusing just for the low hemoglobin if it's less than 50. And in that situation, you have to know, is this an aplastic crisis? Is this a sequestration crisis? Or is this hyperhemolysis? And knowing the difference will completely change the pros and cons of transfusing. What about transfusing just to decrease the hemoglobin S percentage? This is the most common reason that we transfuse. Most patients don't drop their hemoglobins to less than 50. What we're trying to do with the hemoglobin S percentage decrease is typically we want to get it down to less than 30%, which is similar to what a patient with sickle cell trait has, although the distribution of the hemoglobin S is different in that situation. But in any case, getting the hemoglobin S down to less than 30% is our traditional goal when we're transfusing for the goals of decreasing blood viscosity. Hemoglobin SC, you actually might try to get the hemoglobin S down to less than 15%. But in both cases, the overall goal is to get the hemoglobin A, the blood that you're transfusing, up to 70%. There have been a lot of different clinical trials of transfusing for this indication in order to get the hemoglobin S percentage down. And they kind of fall into three categories: pregnancy, perioperative support, and stroke prevention. There are other common indications for transfusion in sickle cell disease with the goal of getting the hemoglobin S percentage down that are not supported by randomized controlled trials, but they are common practice. And that's acute chest syndrome and sickle hepatopathy. So let's go through these. So pregnancy, current guidelines say we should not be transfusing all sickle cell patients when they're pregnant, even though we know that their pregnancy outcomes tend to be worse than patients without sickle cell disease. They have more fetal complications, more maternal complications, but we don't recommend routine transfusion support for sickle cell patients who are pregnant. The times that we do it are those who have had severe complications before they became pregnant, and you can't prevent those complications with hydroxyurea, which is considered contraindicated in pregnancy, or if they have a particularly high risk pregnancy, i.e., twin or triplet pregnancy, or have other chronic organ dysfunction, which puts them at a higher risk. So why do we restrict our transfusions just to these situations? It's largely because of this one randomized controlled trial conducted back in the 1980s that looked at chronic transfusion versus on-demand transfusion for sickle cell patients. And they found that chronic transfusion did not actually result in any improvement in fetal outcomes, although the mothers often felt better. Many patients in that trial were only enrolled after they had finished their first trimester, however. And so the argument now is that the reason we should be transfusing sickle cell patients who are pregnant is to improve the quality of placentation. You really want to improve the organ that is going to actually oxygenate the fetus. That's really the goal of transfusion. So if you're going to do this, you should start relatively early. That's if you're trying to improve fetal outcomes. If you're trying to improve maternal outcomes, then you can start whenever the patients become particularly unwell with their sickle cell disease. Keeping in mind, again, that there are risks with transfusion. And so you have to have a discussion with your patient about how much benefit the transfusion is going to provide them in terms of pain complications versus what are the risk of adverse reactions to that blood. So we do this on a very selective case-by-case basis with pregnancy. Most of the time, you don't need to. But occasionally, if you have a very high-risk pregnancy or an extremely unwell and unstable patient, you might consider it. What about perioperative transfusion support? So there was a landmark randomized controlled trial from 1995 that compared a conservative approach of keeping the hemoglobin sort of around 90 to 110 preoperatively versus an aggressive transfusion protocol that tried to get the hemoglobin S less than 30% while also keeping the total hemoglobin around 90 to 100 or so. That conservative approach, transfusing with a top up to get the hemoglobin up to around 100 or so, essentially achieved a hemoglobin S percentage of 60%. So really, this is a comparison of 60% versus 30% as a hemoglobin S when you're taking a patient in for surgery. And what they found is that there was no difference in outcomes. The outcomes were equally bad for both. 10% of patients had an acute chest syndrome. 10% of those needed to be intubated, typically on post-op day 3. And so people looked at this trial and drew different conclusions. Some people concluded, well, it looks like there's no benefit in transfusing to a hemoglobin S of less than 30%, so we should just give everyone a top-up transfusion to get a hemoglobin of 100. And other people looked at this trial and said, we actually don't know that transfusion does anything at all because there was no untransfused arm. And other people looked at this and said, well, we don't know if getting the hemoglobin S down to less than 30% is beneficial for high-risk patients because those patients weren't included in the trial. So, because there were so many new questions that arose from this study, another study was done. And this was looking at patients with sickle cell disease who randomized them to get transfusion or no transfusion. And if they were randomized to get transfusion, they either had a top-up transfusion if the hemoglobin was less than 90, or an exchange transfusion if the hemoglobin was greater than 90. Most of these patients, again, were low to moderate risk. They did not include a lot of high-risk surgeries. There's nobody undergoing cardiac bypass surgery or organ transplantation, for example. Most of them were sort of bread and butter kind of surgeries that sickle cell patients undergo, like cholecystectomies or hip replacements and that sort of thing. And what they found was that the patients who were not transfused had terrible outcomes, like 10 times the rate of adverse events if you did not transfuse these patients. Again, this was patients who were undergoing what we would consider to be relatively low risk surgeries, like getting your gallbladder taken out or, the hip replacement. And not transfusing these patients led to almost a third of them having an acute chest syndrome. Again, typically a few days after the surgery when the patient is on the ward. It didn't even save much blood because a lot of these patients ended up getting transfused post-operatively when they were quite sick with an acute chest syndrome. I just want to emphasize again, the situations that led to a post-op acute chest syndrome were pretty minor surgeries, right? Tonsillectomies, cholecystectomies, splenectomies, hernia repairs. And if you see a patient who looks pretty well to you, like they're sitting there talking to you, they're comfortable, and they're scheduled for what looks like, pretty minor day surgery, getting their tonsils taken out, you may very well say, I don't think I need to transfuse this patient. But you might actually. This patient is at high risk of having postoperative complications. So, how do you put together all this information? Because I talked about how high risk surgeries were not included in this protocol, and they didn't have enough patients enrolled to really tell the difference between moderate and really low risk surgeries. Like what about somebody who just had a bunion removed? Like, would you need to transfuse that person as well? So there's still a lot of uncertainty. But overall, this is the kind of approach that we take. We look at the low, intermediate, or high risk surgeries. And by low risk, we mean operations on distal extremities, the perineum, i.e., uncomplicated vaginal deliveries, that sort of thing. Probably these patients do not require preoperative transfusion, but anybody else does. And whether they get a top-up transfusion or an exchange transfusion is going to depend on two things. It's going to depend on how complicated the surgery is, and it's going to depend upon what the patient's hemoglobin is. So if the surgery is not high risk and the hemoglobin is less than 90, you could probably do a top-up transfusion. But if the surgery is high risk or the patient's hemoglobin is already greater than 90, you probably need to do an exchange transfusion. So it's complicated. You have to assess each patient individually, looking at their particular situation and the surgery they're undergoing. Now, because we know that transfusions are high risk in patients with sickle cell disease, sorry, that surgeries are high risk in patients with sickle cell disease, There has historically been a practice of screening patients for sickle cell disease right as they're getting ready for surgery. And this is typically done with a SickleDex test, which is looking for solubility of hemoglobin when you expose it to a hypoxic environment. The problem is this test will pick up patients with sickle cell trait as well as those with sickle cell disease. And you'll only be able to tell the difference if you then send the patient for a hemoglobin electrophoresis or high performance liquid chromatography. That might take up to a week for you to get the results back. So you end up catching a lot of sickle trait patients when you do this approach. And sickle trait is 50 times more common than sickle cell disease. So do we really need to perform this test in order to catch patients with sickle cell disease? We have to keep in mind that the vast majority of patients with sickle cell disease will already know it by the time they're age 10 at least. They'll have had complications from it. And anyone younger than that, and I've got statistics here for Ontario, but this is also largely true for Quebec, you will have picked up by newborn screening. So it's much more valuable to get a good history and physical from your patient than it is to do a SickleDex test. Just ask them, do you have sickle cell disease? If they do, almost all of the time they will know it and they'll tell you. And that's a better approach. At the very least, get a CBC and look to see if they're anemic. If they're not anemic, they probably do not have sickle cell disease. And if they are anemic, you should investigate why, regardless of whether it's sickle cell disease, because anemia itself needs preoperative management before you send a patient to surgery. What about stroke prevention? Lots of clinical trials here, but they're all in children. So I won't go through each trial one by one, but the net result of all these trials is that we know that transfusion is first-line therapy for primary and secondary stroke prevention. Primary stroke prevention in patients who are at high risk of stroke, and secondary prevention in patients who have had a stroke. If you have a patient who has had a stroke, we know that transfusions are very effective at preventing them. We do not know how to stop those transfusions without having strokes recur. We haven't figured out an off-ramp. But for patients who are being transfused for primary stroke prophylaxis, there is evidence that after a year of that, you can cautiously transition them to hydroxyurea. Patients who have silent infarcts, we don't actually know how to manage these patients. We do know that transfusion will prevent more silent infarcts. It will also prevent overt infarcts. But at the same time, if you start looking for silent infarcts in all patients, and in fact, we are doing this now, we're doing routine MRI brains on all of our sickle cell patients, we find a lot of them have evidence of silent infarcts. We can't transfuse all of those patients. There's not enough blood. We don't really know whether hydroxyurea might be effective at preventing progression of silent infarcts, at least in some cases. So it's kind of a case-by-case basis. So that's the situation with transfusion for stroke prevention in children. In adults, we don't really have any clinical trials, and it gets really confusing because patients with sickle cell disease can develop strokes for all sorts of other reasons that have nothing to do with their sickle cell disease. They can have cardioembolism from their atrial fibrillation, for example. So you have to first assess, do you think that stroke was secondary to their sickle cell disease? If it was, we assume that they're going to benefit from chronic transfusion as well, the same way pediatric patients would. But we also have to keep in mind that adult patients are much more likely to present with a hemorrhagic stroke than an ischemic stroke. Now, the pathophysiology is the same. This is resulting from chronic vascular occlusion, and then you have a growth of ectatic blood vessels around that area of occlusion, and it's those secondary proliferative blood vessels that tend to bleed. So we still think that patients who with sickle cell disease who have had a hemorrhagic stroke would also benefit from transfusion, but we don't initiate those transfusions while they're actively having a hemorrhagic stroke. We wait for the bleeding to slow down, and then we would introduce transfusion support. Putting an apheresis circuit to a patient who is actively having a hemorrhagic stroke may actually make that hemorrhage worse. So wait till the bleeding has stopped, assess the degree of underlying vasculopathy, and then start the transfusions to prevent any further vasculopathy from developing. Acute chest syndrome, we don't really have any randomized controlled trials, but we do know that this is a very common complication of sickle cell disease, and it is a common cause of death. And so transfusions have been routinely attempted as a means of decreasing morbidity and mortality from this particular complication. What is an acute chest syndrome? An acute chest syndrome is any new pulmonary infiltrate accompanied by fever or respiratory symptoms with a patient who has sickle cell disease. That means that you cannot tell the difference between this and community-acquired pneumonia. And in fact, very often patients with sickle cell disease will have both at the same time. They will present with acute pneumonia or community-acquired pneumonia, and that will then be complicated by an acute chest syndrome. The pathophysiology is more than simply infections, although that can drive a lot of these. You can also have the release of necrotic bone marrow following a painful vaso-occlusive crisis. You can develop thrombotic complications as a result as well. And so there's all sorts of different interventions that you might need to consider. So antibiotics are generally recommended for all patients with an acute chest syndrome. We would recommend looking for thrombosis. If you see it, then you should anticoagulate as well. Doing what you can to maximize oxygenation, i.e., get them breathing well, make sure they're not splinting from pain in the rib cage, make sure that they are not overhydrated, that they're not so sedated from analgesics that they're not hypoventilating, give them lots of supplemental oxygen. All of these things are really important. What about transfusion? So we know from a large observational study that transfusions tends to benefit oxygenation in patients with sickle cell disease. We don't have a randomized controlled trial to show that an exchange transfusion is better than a top-up transfusion. But we do know from case series that many patients with acute chest syndrome who get a top-up transfusion will continue to deteriorate until they have an exchange transfusion, which suggests that there are some patients with an acute chest syndrome who are sick enough at presentation that they should be sent immediately for an exchange transfusion. How do you know which patients those are? Well, we don't really know, but we do know prognostic markers for a bad outcome with acute chest syndrome. And if your patient has any of these things, that is usually a clue that they are going to not do well, and therefore you should be making arrangements for an exchange transfusion. You may need to do a top-up transfusion first. If the patient is very anemic, they can't even be put on an apheresis circuit, for example. But you should start making arrangements. You should call for the apheresis service at your hospital to come and assess this patient. And if you're at a hospital that doesn't have an apheresis service, you should start preparing to transfer your patient out if they have any of these things. What other situations might you need to transfuse to decrease your hemoglobin S percentage? Intrahepatic cholestasis can be a very insidious but fatal condition, particularly in adults. And it's a form of intrahepatic cholestasis. And these patients will present with right upper quadrant pain, coagulopathy, hyperbilirubinemia. Their ALT may not be that elevated. And if you do abdominal imaging, you'll see that they have significant hepatomegaly. Do not try to biopsy these patients to confirm the cause. This is a clinical diagnosis, and biopsy is different. But once you have made that clinical diagnosis, exchange transfusions do appear to be a benefit of turning it around. There are all sorts of, if all else fails, you can try transfusion. Priapism, malleolar ulcers, proliferative retinopathy, avascular necrosis, acute kidney failure, pulmonary hypertension. We don't know if transfusion benefits these patients. We don't have any trials to support that conclusion. But if you have tried all your local therapies and the patient is progressing regardless, you can consider transfusion. You can also consider hydroxyurea and/or phlebotomy if the patient is not acutely unwell, because we know that hydroxyurea and phlebotomy have a slow effect. But if you don't have the privilege of waiting, if your patient is critically unwell, or if you tried hydroxyurea phlebotomy and it has failed as well as these local therapies, then you can try transfusion. So this is quite a lot to take in here. And so keeping it all straight is not easy, but generally speaking, we would consider transfusions to be appropriate for stroke, either acute presentation or prevention, or stroke equivalent like retinal artery occlusion. It's reasonable with splenic sequestration, intrahepatic cholestasis, acute chest syndrome, aplastic crisis with small volumes, preoperatively, supportive hemorrhage, and for patients who are having recurrent pain crises that you cannot manage with hydroxyurea, either because the hydroxyurea is not working or because the patient can't take it because they're pregnant, for example, transfusion would be reasonable. Maybe it works for priapism, maybe pulmonary hypertension, maybe renal failure. It may be of benefit in certain pregnancies for fetal benefit, maybe for severe sepsis. We don't really know. But if there's one thing you should remember is when you should not be transfusing. You should not be transfusing in a patient who has compensated stable anemia, unless the hemoglobin is less than 50. And even then, as I mentioned, you should have a pretty good idea what drove it down there. Definitely don't transfuse for uncomplicated pain crises. You probably don't need to do it for preoperatively for minor surgical procedures, for patients who have non-surgical AVN, or for uncomplicated pregnancies. So we probably are over transfusing the patients who are coming into emerge with pain crises. Those patients often should not be transfused. The patients who we put on regular transfusions are the ones who we have assessed as being of benefit, typically in an outpatient setting in a hemoglobinopathy clinic. Now, when you're transfusing, you also have to be very aware that the blood has to be carefully selected for these patients. We know that patients with sickle cell disease are at high risk of making antibodies. This is due in part due to differences between typical blood donors and sickle cell patients in the types of antigens on those red cells. And we also know that very often these antibodies will disappear. So you'll make one after transfusing a patient, and then that will evanesce, and you won't see it when they present the next time. And this is a particular risk when patients are getting itinerant care, going from hospital to hospital. In which case they get transfused at one hospital and then they're discharged and they present at another hospital a few months later. Any antibody they might have made, we don't know about. So because antibody formation is common in sickle cell disease, because it is easy to miss, and because the consequences are fairly severe, if you don't honor that, we emphasize prophylactic antigen matching as being a really important part of managing sickle cell disease, meaning that you have to provide extended matching of red cells. This often fails to happen because the blood bank doesn't know that the patient has sickle cell disease. It's really important that the blood bank be told this is for a patient with sickle cell disease. It's also important to give the blood bank enough time to find those units. It sometimes can take days to get properly matched blood. So get that group and screen when they first come into the hospital, just so we know how hard it's going to be. And ideally, you should actually be getting a group and screen on a patient the very first time you encounter them in any situation so that you can genotype those patients, because genotyping is more accurate in the degree of matching it can allow you with. Now, I talked to you about the risks of antibody formation in sickle cell disease. What are those risks? The risk that any patient that you transfuse who makes an antibody faces is an anamnestic response if they are re-challenged against that antigen, because that anamnestic response will lead to a much more rapid increase in antibody titer. Those antibodies will have higher avidity, and you will end up destroying that red blood cell. That's what happens to any patient who has a delayed hemolytic transfusion reaction, including patients with sickle cell disease. And you can often see this because if you do a hemoglobin electrophoresis, all that hemoglobin A containing blood that you transfused is gone. The problem is that this can often progress into something called hyperhemolysis, which is when the hemoglobin is less than it was before you transfuse the patient. So the hemoglobin drops to below the pre-transfusion level. And very often, you won't see an antibody. And in this situation, you are risking hyperhemolytic transfusion reactions, which themselves can be life-threatening. Every time you transfuse, the patient becomes more anemic. They get sicker and sicker until they die. And I have lost patients to this complication several times over. It is absolutely devastating. We still don't understand exactly what is driving this. Increasingly, it seems, and this is mostly my opinion, but I think it's, I think other people are seeing this as well. The bad actor in all this is plasma-free heme. Plasma-free heme occurs when you have intravascular hemolysis, and normally it is recycled into bilirubin and into ferritin as the iron is taken out and used for reuse. But if you exceed your body's capacity to break that heme down, it has all sorts of toxic effects. It can act on the blood vessel wall and actually trigger vaso-occlusion. And in fact, the very first case of hyperhemolysis was termed a delayed hemolytic transfusion reaction presenting as a sickle crisis. Patients with hyperhemolysis will present with pain, and then their hemoglobin will fall. So pain is often the first presenting symptom. But the heme has other effects as well. It binds to existing antibodies and induces something called heme-mediated polyreactivity. And we can sometimes see this in blood bank. It's like suddenly there's this junk in all their antibody panels. There's some sort of non-specific reaction. And what that may be is the heme is binding to that patient's antibodies, which are then binding to all your panel red cells. And that may end up destroying not simply the blood that you transfused, but the patient's own blood. We know that heme can activate complement. Complement, when it's activated to a high enough degree, can cause bystander lysis. So the complement starts to coat even red cells that were not the target of that initial immune target, i.e., patients will have complement-mediated lysis of their own blood, not just the blood that you transfused. And we also know that heme can activate macrophages, decreasing their ability to clear apoptotic cells. And those apoptotic cells can then have an increasingly inflammatory effect and lead to a progressive SIR syndrome with organ dysfunction, hypotension, and so on and so forth. So we don't know for certain. There are probably other pathophysiologies underlying this as well, but heme does seem to be important in several different avenues. The main thing with hyperhemolysis is to recognize that transfusing will make this patient worse. And so you have to stop transfusing, even if they are severely anemic, and instead do what you can to try to shut down their immune system. We typically start by targeting their macrophages with IVIG, sometimes steroids. You might consider tocilizumab. Because their retics are often low, you have to give them high doses of erythropoietin to increase erythropoiesis. And if that fails, you can try eculizumab to shut down complement, or you can use rituximab to clear the way for another transfusion. The thought being that that will at least prevent any new antibodies from being triggered by that new unit of blood. But we typically don't do this until your hemoglobin is less than 30. We also know that hyperhemolysis recurs in at least 50% of cases. So once this has happened, you can't transfuse that patient again. You've almost made them a Jehovah's Witness, and they have to know nobody can ever transfuse you again. How do you manage it? Stop transfusing and try to increase oxygen delivery through other means. Driving the PaO2 up can actually have a significant benefit, even if you're not going to see it in your SpO2. You will see it if an arterial blood gas is collected. But the key thing is not to titrate the oxygen level down when the oxygen sat is 100%, because what you're trying to do is trying to increase the oxygen delivery in the plasma, which pulse oximetry will not be measuring. High doses of EPO may be of benefit. Hemoglobin-based oxygen carriers have been tried, although they're often hard to get now, so it's not something we often recommend. When we're deciding when to transfuse a patient, we are doing this very cautiously. You have to do a real careful risk analysis. Chronically transfused patients appear to be relatively safe from this. Episodically transfused patients are at higher risk, particularly if they haven't received at least 12 units of blood, or if they've ever had an antibody, or they've ever had a delayed hemolytic transfusion reaction. In these patients, we may suggest that you give them rituximab as a pre-medication before you transfuse if they're at very high risk. Actively surveying for these patients is really important. It's really useful to do a hemoglobin electrophoresis immediately after every transfusion, because if the patient then comes back in within a month with a pain crisis, you can repeat that hemoglobin electrophoresis. And you can see if they are starting to destroy the blood that you transfused, i.e., if half of it is gone within a month, that patient is at very high risk of hyperhemolysis, and you should admit them to hospital. And with this protocol, actively surveying, they still found that 4.2% of these patients developed hyperhemolysis, and 12% of those patients died as a result. Other things to think about: sickle trait blood, totally safe to transfuse. It will mess up your hemoglobin S measurement, but it's not dangerous to give. Fresh blood theoretically might be a benefit, not something you should delay a life-saving transfusion for. Much more important to give antigen-typed units, and genotyped matching, if you can, as well, is even better if you can do this with enough time in advance. So, to make transfusion safe for patients with sickle cell disease, it should be done carefully. We should be trying to increase the diversity of our donor population. We need to get better communication between the blood bank and the clinical services. You need to have better communication between different hospitals that care for these patients so that they can share the serology history. But the safest option is, before you transfuse a patient, get a heme consult. Okay, and that's the end of my talk. And I don't know if I've left any time here for questions, but I'm happy to take some if you have any.
Thank you very much, Jacob, for this wonderful talk. Very complete, really highlights difficulties of treating these patients in really all stages of their life. We don't have a lot of time, but I would like to know if there's anybody in the audience. Or yes.
As just a question, if all else fails and the patient is coming in the pull-out crisis, is there a role for to support these patients, or would that be futile? Like, for instance, acute chest syndrome, that sort of thing. Do any of these patients get crashed on ECMO until everything settles out?
So I have seen patients with sickle cell disease go on ECMO. The ECMO circuit itself is almost certainly going to cause worsening hemolysis just because of going through the circuit itself. So typically we would do an exchange transfusion first, and only if that does not improve their respiratory status would we be putting them on ECMO. But yeah, some patients, even with an exchange transfusion, the lungs are so shot that they can't oxygenate.
Thank you. Yes.
Can you tell us about the heart muscle itself? Do they get hypertrophy with all these transfusions? What do you see in the heart muscle? Do they have a high risk of developing preserved heart failure as they age?
So the most common cardiac complication we see with sickle cell disease is pulmonary hypertension. And we screen for that by doing echocardiography, looking particularly at the RVSP or the TR jet. And that can progress to cor pulmonale, where you actually have left-sided failure as well. And that's preceded typically by cardiomegaly, ventriculomegaly, biatrial enlargement, and that sort of thing. We don't typically see iron overload with sickle cell patients for reasons that are not entirely clear, at least not cardiac iron overload. They'll develop hepatic iron overload, but it doesn't seem to get into the heart the same way it does with thalassemia patients. Patients with sickle cell disease can develop, traditional ischemic heart disease like atherosclerosis. That can happen too. It will manifest typically like with wall motion abnormalities regionally, positive stress tests. You'll see it on an angiogram. But pulmonary hypertension is the more common complication.
And if I may ask, we've recently had 2 young patients with like literally MI, and it was thought to be coronary sickling, and terrible rise in troponins, then improve with time, and it's difficult to know exactly what to do with them. Right.
Yeah, I'll tell you, I'm personally a little bit skeptical when a patient comes in with high troponins and clear coronaries with the conclusion, oh, the sickle cell disease must have got their microcirculation. It's possible, I suppose. But I would wonder as well about other things like viral myocarditis and that kind of thing, particularly if they recover afterwards. So it's possible, but I've been told that too by cardiologists, say, oh, this is sickling in the microcirculation, and I've been skeptical. I've wondered if it's more a viral myocarditis.
Any other comment? I think that will be it. But thank you very, very much, Jacob, for this wonderful talk. I think it raises additional questions. We'll have to talk more about sickle cell in the future as well. Thanks a lot. Thanks, everybody.
Thanks for the invitation.